Assalamu alaikum and welcome to my presentation on fungal pneumonia in children. Pneumonia is the inflammation of lung parenchyma. It's a form of acute respiratory infection that affects the lung. When an individual with pneumonia, the alveoli are filled with pus and fluid, and it makes breathing painful and limits oxygen intake. Pneumonia is one of the leading causes of death globally, and Bangladesh is placed among the top 15 countries due to pneumonia deaths, and in each hour, 2 to 3 children are dying due to pneumonia in this country. Pneumonia can be classified in various ways. According to acquisition of organism, it can be community acquired or nosocomial or hospital acquired. Pathologically, it may be lobar pneumonia or bronchopneumonia, and from source, it may be infectious and also some non-infectious pneumonia available like chemical pneumonitis or hypersensitivity pneumonitis, etc. Though bacteria and viruses are among the top organism causing pneumonia, fungus are relatively rare, but it can affect typical risk groups. So fungal pneumonia. Fungus are basically of 4 types, depending upon presence or absence of hyphae. They may be yeast-like, mold, or dimorphic. Some are pathogenic fungus when infect anyone, and some saprophytic infects only immunocompromised persons. There are some risk groups who are susceptible for fungal pneumonia like primary or acquired immunodeficiency, malignancy-related factors like malignant hematopathia and especially with febrile neutropenia, prolonged hospitalization related like long-term ICU care with invasive medical procedure and also immunosuppressive drugs. There are some healthy risk group who can be infected by fungus also, like who are in close contact with birds like pigeons or hens, and also pet animals like cats and dogs. These persons are victim of septic tank drowning and now develop fungal pneumonia. So these are 2 dangerous habits. Clinically, fungal pneumonia are like other pneumonia initially, and it is very difficult to differentiate them from other causes of pneumonia. But you have to have a strong suspicion, and the typical risk factor ignite this suspicion. I will talk about individual fungus, and I will start with aspergilloma. In simple aspergilloma, where there is a ball of coalescent myelal hyphae, and they colonize in pre-existing cavity, especially in tuberculosis and sarcoidosis, and they give rise to a typical radiological finding. This is called air crescent sign, and this is more evident in CT scan. Another one is allergic bronchopulmonary aspergillosis, occurs in patient with chronic and difficult bronchial asthma and cystic fibrosis. After inhalation of the spore, they colonize and germinate into hyphae, chronic allergic inflammation, and ultimately tissue injury. And net results are airway remodeling, chronic bronchial inflammation, mucus infection, eosinophilia with raised IG, and eventually bronchiectasis. And if you do radiology, you may find finger in glove sign with central bronchiectasis and also mucus plugging with high attenuation mucus. There are some diagnostic criteria with skin prints test, antibody, and radiology. Another one is airway invasive pulmonary aspergillosis, particularly after solid organ transplant patient comes with the feature like acute tracheobronchitis, bronchiolitis, or bronchopneumonia. And in radiology, you may find tree in bud sign. Angio-invasive aspergillosis also occur in immunocompromised host with neutropenia, and they invade small or medium artery, giving rise to a necrotic hemorrhagic nodule or infarct in lungs. Typically, you may find halo sign and also reversed halo sign. Chronic pulmonary aspergillosis are of 3 types: chronic cavitating, necrotizing, or fibrosing, and they may occur in patient with malnutrition and diabetes mellitus or pre-existing lung disease. Here in the CT scan, you can see both necrosis and also some fibrosing pattern with decreased lung volume. And in these pictures, in X-ray and as well as CT scan, there are lots of finding like abscess formation, cavitation, and ultimately in right side necrotizing pneumonia. So when we suspect or diagnose a case of aspergilloma or aspergillosis, we have to start treatment promptly with antifungal drug, and our first choice is voriconazole, and alternate are flucytosine with amphotericin B. Cryptococcus neoformans typically cause fungal meningitis, but they can also infect lung, and they're found in soil and bird droppings and more common in immunocompromised host. In chest X-ray or in CT scan, some subpleural single or multiple nodules may be seen with perihilar diffuse nodular reticulonodular pattern or area of segmental or lobar consolidation, like these pictures. So treatment of cryptococcosis is in milder cases fluconazole, in severe case amphotericin B followed by fluconazole, and lifelong maintenance may be needed in some HIV/AIDS patient. Histoplasma are found in soil and bird excreta, and subclinical infection followed by calcified nodules and imaging are much resembling like a TB, and I'm not going with the radiology. And treatment of histoplasmosis is in severe ill or immunocompromised patient amphotericin B, and milder cases azoles or triazoles. In patient with severe hypoxia or ARDS, corticosteroid may be needed. And those who have severe hemoptysis or recurrent pneumonia, surgical repair of bronchopulmonary fistula is needed. Pneumocystis jirovecii are seen in AIDS, organ transplant, chemotherapy, steroid receiver, and also cystic fibrosis patient. In X-ray may be normal or with perihilar opacity. In CT scan may have GGO, that is ground glass opacity with consolidation on thin-walled cavity. Drug of choice is cotrimoxazole. Mucormycosis is infected by inhalation of spores in immunosuppressed condition. Imagings are non-specific, and reverse thalassine may be found. Mainstay of treatment is amphotericin B. Azoles are resistant. Primary lung lesion in case of candidiasis is unusual, and Candida auris is an emerging threat at ICU. And risk group are preterm very low birth weight and extremely low birth weight pneumonitis with central line or neutropenia. Clinical features mimic septicemia, and in investigation, blood culture, urine examination for budding yeast, ultrasonography of kidney for fungal ball, CSF examination may be needed, and treatment is amphotericin B and fluconazole orally twice or thrice weekly in extremely low birth weight babies in NICU recommended. There are three modalities of diagnostic tools in fungal pneumonia. You may have direct evidence by doing blood or urine culture, but preferably examination of bronchoalveolar lavage obtaining from fiber optic bronchoscopy. Indirect evidence are found by galactomannan detection or D-glucan detection, and also PCR ELISA, and modern technique are T2MR and T2 Candida. And imagings are anatomical imaging, as I have already mentioned, with molecular imaging and hybrid imaging. T2 panel technique requires only 4 ml of blood in 3 to 4 hours. It will give you result with more than 90% sensitivity and more than 95% specificity. When there is a lung lesion, CT scan is the imaging of choice. When there is CNS or pharyngeal sinus infection, MRI is the choice. But when there is disseminated infection with cryptic lesion, you may have to do FDG, PET CT or MRI, which is called hybrid imaging. As in this picture, a patient with systemic and disseminated candidiasis, hybrid imaging was done. And sometimes other tests are needed. I have already mentioned individual treatment, and besides antifungal therapy, neutrophil recovery with colony stimulating factor with correction of hyperglycemia, acidosis, and selected surgical options are also available. And complication in untreated cases are disseminated to other sites, and sepsis syndrome, blood vessel invasion, bronchopulmonary or tracheoesophageal fistula, mediastinal fibromatosis, and broncholithiasis. So in conclusion, I must say that when you deal with such patient, you have to act like a detective with a strong suspicion, with teamwork and targeted and rational treatment. So thank you.